Lloyd Healthcare, I welcome you all for this Lloyd Journal Club program. I welcome Dr. Arundhati Dasgupta ma'am as a speaker for this program. I welcome Dr.Ameya Joshi sir as a speaker for this program. This Lloyd Journal Club program is a scientific initiative taken by Lloyd Healthcare. The objective of this initiative is to disseminate latest scientific information from renowned journals like NEJM and Lancet. And also, it provides platform to the HCPs to discuss queries related diabetes management with the KOLs. KOLs like Arundhati ma'am and Ameya sir. So today we have this great faculty with us. And this is the virtual program, and it is broadcasting across India. Now I can see 1,600 attendees are attending this program. And we are expecting more than 2,000 attendees will be there. With this, I request Sanika to introduce today's faculty with the help of PPT. Over to you, Sanika, please.
Thank you so much, sir. So a very good evening, and I'm just sharing my screen. So a warm welcome for the Journal Club. And with great pleasure, I introduce our speaker for the day, Dr. Arundhati Dasgupta, MBBS MD Medicine, and ma'am is a very renowned endocrinologist, also having a fellowship of the American College of Endocrinology. Ma'am is a director and senior consultant endocrinologist at the Rudraksh Super Specialty Care, Siliguri. Ma'am has been a former associate consultant, Division of Endocrinology and Diabetes. Ma'am has been a published author in leading national and various international journals. Ma'am has also been a co-author of multiple global expert consensus statements. Ma'am has been a contributor to several medical textbooks and RSSDI yearbooks. Along with this, ma'am has also been a faculty speaker at over more than 200 regional, national, and international forums. With her services and her support in the Educational Forum in Pharmaceutical Sciences, ma'am has been a recipient of the Icon of Endocrinology Award 2024 and also the Outstanding Community Service Award of 2025. With this, ma'am has also conducted more than 150 diabetes and lifestyle awareness programs across North Bengal, Sikkim, Bihar, and Nepal. And with her service towards medicine, ma'am has also been a regular contributor to media-based public health education initiatives all over India. So, ma'am, it is a pleasure that we have you for our Journal Club program for the day, and a warm welcome from Lloyd's Healthcare for the same. A warm welcome, Dr. Arundhati Dasgupta, and it is a pleasure that we are having you here today.
Thank you so much. Thank you.
Yes, ma'am. Going ahead, we have our speaker for the day, second speaker for the day, Dr. Ameya Joshi, MDM endocrinologist. Dr. Ameya Joshi is the director of Diabetes and Endocrine Clinics, Mumbai. Sir is consultant in charge endocrinology at Bhaktivedanta Hospital and Research Institute and Karuna Hospital at Mumbai. Sir has been recipient of IDF and European Society of Endocrinology Young Scholar Grant. Sir is a vice president of Maha Endocrine Society and also has been the scientific secretary at the ESICON 2019. With this, Sir has been recipient of multiple national awards, including the Osler Award and Shireen Mehtaji Gold Medal as well. With this, he has also been actively participating in the study and the research materials, thus has been a published author with more than 30 papers in leading national and international journals, including the Journal of Postgraduate Medicine, Indian Journal of Endocrinology and Metabolism, and Osteoporosis International Journals. A warm welcome, Dr. Ameya Joshi, and it is a pleasure that we are going to have a session from your end as well in today's Journal Club for the day. A warm welcome, sir, once again. And to begin with this, we have Dr. Arundhati Dasgupta today, who will be talking and giving us insights on the topic of improving the chronic kidney disease outcomes in diabetes. And she will be spreading some light on the established trials and also adding her own experiences from her real life evidences and the cases. Followed by which we will be having the session from Dr. Ameya Joshi, who will be having and putting some light on the uses of GLP-1 and gastric inhibitor polypeptides in the heart failure with preserved ejection fraction. So with this, I would like to invite our speaker for the day, Dr. Arundhati Dasgupta, to kindly initiate with the session. And with this, over to you, ma'am, to take out the session for the day.
Thank you so much. Thank you for the very warm welcome. Please allow me to share the slide in a second. So good evening, everybody. Today we'll be discussing on basically improving the chronic kidney disease outcomes in diabetes. We'll take a look at what is the data that we have till now, what is the evidence that we have. Thankfully, we are today in an era where we can talk beyond glycemic control, and we have a number of molecules in our hand which are not only kidney safe or cardiac safe, but they are actually also providing benefits much beyond HbA1c control. So trying to take a look at some of these molecules and trying to understand, what do we have in our hands today if we are trying to improve the chronic kidney disease outcomes in our diabetic patients. So this is how we are going to take it. Firstly, trying to understand what is the magnitude of the problem that we're trying to solve. How big is it? We'll take a look at the 2022 KDIGO guidelines. And we'll try to understand about the SGLT2 inhibitor in terms of the cardiovascular trials that have been done and what have they showed us in terms of the CKD benefits. A basic holistic approach, look at the role of finerenone and CKD in patients with diabetes, and then try to understand about the role of GLP-1 receptor agonists and diabetic kidney disease. Then lastly, about the risk-based GDMT for CKD in type 2 diabetes. So firstly, looking at what problem are we trying to solve, or rather, I would say, what is the problem in our hand? These are the figures. We know 537 million diabetics, of which 95% are type 2 diabetics, 5% are type 1 diabetics, and half kidney disease. We do know that out of every 10 amongst type 2 diabetic patients, like 4 people progress to CKD, while in type 1 it's like 3 patients progress to CKD. And the progression is we know about the CKM dynamics, the kidney, the cardiovascular, the metabolic, and all of which is like involved leading on to one, kind of accelerating the progress of the other, and thereby the entire pattern wherein the chronic kidney disease patients progress onto cardiovascular disease and vice versa. We've had the KDIGO guidelines 2022. Now, if we look at the pyramid that has been designed by KDIGO, we can see that the baseline remains with the diet and exercise and, of course, smoking cessation and weight control, which has been taken up in a very strong way. Now, we also understand the importance and the magnitude of the role of weight control. The first-line drug therapy by KDIGO, metformin in terms of, basic reduction, SGLT2 inhibitors, RAS blockade, and statins. Now, when they spoke about the additional drugs in terms of cardiac and renal protection, KDIGO has mentioned the GLP-1 receptor agonist, the NSMRA, and the antiplatelet therapies. Okay, so this is what we were talking about, actually, like trying to understand what problem are we trying to solve, and then we'll take a look at the KDIGO guidelines, and so just basically just repeating what problem are we trying to solve. We'll go through this very fast. That that 4 amongst 10 in type 2 and 3 amongst 10 in type 1. And this is the magnitude of the problem that we were discussing, the cardio-renal-metabolic issue, one leading on to the other and leading to a vicious cycle wherein, it's a big problem in our hands today. When we look at the numbers and we say that like 4 out of every 10 amongst the 5-10 million are having a kidney disease problem, then that is actually saying a lot. So this is what we were talking about, the KDIGO guidelines and the basic pyramid. You can see that what I had just spoken about, the figure there, the diet, exercise, smoking, the metformin, SGLT2, RAS, and statin being the next in line, GLP-1 receptor agonist, antiplatelet, NSRNA being the third, the additional drugs, and of course, the top of the pyramid, glycemic control, blood pressure control, and lipid management being primary. Now, as we move on to understand about the role of SGLT2 inhibition in the what has been seen in the cardiovascular trials, the primarily cardiovascular trials, and what have we seen in terms of reduction? Of course, we've seen the reduction in the major adverse CVD events. We've seen results with heart failure, with empagliflozin, with canagliflozin, with dapagliflozin. We've seen results in terms of atherosclerotic CVD, the 3-point MACE, reduction in terms of MI, stroke, and CV death. Primarily for CV death, we've seen results with empagliflozin and dapagliflozin. And when we're talking about the renal outcomes, we have seen results in terms of decrease in macroalbuminuria, the GFR decline, and the time to kidney failure. So basically, in the presence of the CKD, we saw dual benefits. We saw CVD benefits, and we've seen the CKD benefits as well. So most of the cardiovascular trials Yeah, we'll just take a look at the role of dapagliflozin, because that is what we're trying to discuss out here. This is one of the studies that were published in 2020. This is looking at dapagliflozin in patients with chronic kidney disease. Now, if we start looking at the difference from dapagliflozin and placebo in terms of the primary endpoints, composite endpoints, and the renal specific composite endpoints. So you can see there that over a period of time, the two arms start separating. And the separation is not really something which starts greatly after it has been initiated. It is, you can see, by the end of 4 months, 8 months, 12 months, you're gradually seeing the curve separating. And it is as the time progresses with the continuous usage of the molecule, the two arms are getting widely separated from each other, thereby telling us that as you go on using this molecule, the composite outcomes get better. And similar is the projection that has been seen with the renal specific composite outcomes. Here too, initially, though they were like kind of together, and as you're continuously using this over a period of 20, 24, 28, and 32 months, you can see that the two arms are distinctly separate from each other. And that means that the role of dapagliflozin in terms of the benefit from these endpoints is like significant. We've seen that. This is again about the change in from the baseline in the estimated GFR. So you can see when you started off at the placebo and dapagliflozin, it came down, and then after a point it was like it kind of plateaued, and then it kind of stayed there and it went downwards. So basically, when you're looking at the change, where did you start off with and how you're reaching, and looking at the difference between placebo, it's not like the patients on dapagliflozin are not going to have a decrease in the GFR. They are, but in comparison to the decline with the placebo, the rates are lower. The progress of the decline in GFR is actually lesser when you're using it, when you're using dapagliflozin as a therapy as compared to placebo. This is in the same study that came out in NEJM in 2020. Now, if we try to understand about the different cardiovascular trials, the DAPA-HF, DELIVER, and try to recognize in terms of kidney function. So you look at the heart failure events and the cardiovascular death by the kidney function. So you can see there in terms of the composite of all-cause mortality, the all-cause mortality per se, the ESCKD or eGFR less than 15, a decline in GFR. These were the points that we looked into. More than 50%, more than 40%. So when you're comparing dapagliflozin with placebo, you can see these results. You can see that in terms of the hazard ratio, it's like 1.04, 1.11, 1.11. And as you can understand, anything beyond 1 is actually very significant. So this was an analysis done, which came out in JAMA in 2023. If you look at the DAPA-HF heart failure results also, when you're trying to understand the difference, you can see there the hazard ratio values 1.12, 1.24, 1.20, 1.02, 1.33, and to the extent of 1.39 when you're assessing the decline in GFR more than 50%. Coming to the DELIVER trial, the DAPA versus placebo, initially, if you're looking at the all-cause mortality or composite, it is 0.98. But if you're looking primarily at the GFR less than 15 or the ESCKD category, you can see there it's like 1.51. So what is evident is that when you're looking at these studies, the outcome with dapagliflozin has been quite significant in comparison to placebo. This is a study again that was done with canagliflozin there, the difference between the primary and the second renal composite outcomes being shown. This is from the change from the screening level in the estimated GFR, and that is also, you can see there, the placebo and then the canagliflozin picture being not very different from what we saw. So this is the triology. You're looking at credence, and then you're looking at DAPA-CKD, and then you're looking at EMPA-kidney, right? So credence, remember, this was about type 2 diabetics who had a GFR of more than 30 and an ACR of value of more than 300. DAPA-CKD had GFR of more than 25, ACR of more than 200. EMPA-kidney had a higher level, GFR of more than 45 and ACR of more than 200. So when you're trying to assess the difference between these three trials, you can see the canagliflozin story, and then we come on to the dapagliflozin story, and then we look at the empagliflozin story. Now, the difference in the outcome of these is evident. So when you're looking at a holistic, today we will be, whenever we're treating any patient with diabetes and CKD, we will want to put in, everything together so as to bring about maximum effect, however, if tolerated, of course, and if the patient is within that category. For example, first line therapy, if you're talking about metformin, the GFR has to be more than 30. SGLT2, again, data till more than 20, so up to 20 or 25. And then RAS inhibition, unless contraindicated, at maximum tolerated dose, if hypertension is positive, of course. And statin, you would want to put in for every patient, moderate or high intensity statin. So additional risk-based therapy, we have a lot of data with GLP-1 receptor agonists. Also, we'll be talking about the non-steroidal MRAs, very briefly. And in terms of, as an add-on to the RAS therapy, you could be putting in a calcium channel blocker and or a diuretic. And now with whatever the data that we have with finerenone, we would also want to put in a non-steroidal MRA there. And if at all need be, you would later on go on to a steroidal MRA in terms of like hypertension. Statin-wise, you put in statin, additional risk-based therapy, might want to choose an antiplatelet therapy. And then if you're not reaching your targets, you could want to add on an ezetimibe or a PCSK. Of course, that's not very easily available, but you can use icosapentaethyl if your triglyceride levels are high and otherwise you're not reaching target. So basically, first line therapy would basically ensure that you have covered almost all the aspects, and additional risk-based therapy would want to cover all the extra areas of the kidney progression that might be there. Okay, now finerenone has given us very good data with the Fidelio and the Figaro trials. Now, let us look at what Fidelio told us, that the GFR decline, you're looking at 40% kidney failure, kidney disease and death. And when you're comparing with placebo, we could see a distinct difference between the finerenone group and the placebo group. And if you're talking about Figaro, where you're looking at MI, stroke, heart failure, hospitalization, CV death, there too, the data, with the finerenone, you can see that the arms separating significantly, the difference being seen with the placebo group as compared to finerenone. As you go on to the fine heart wound analysis, the data in heart failure and CKD. So the primary endpoint was CV death, and the secondary endpoints were kidney and composite endpoints or heart failure for hospitalization, CV death. So if you look at it one by one, let's see CV death, and you're looking at comparison with placebo, you can see it's in favor of finerenone. Yeah, if you're looking at the kidney composite endpoints, very significantly, hospitalization, heart failure, CV death, atrial fibrillation, all-cause death, all-cause hospitalization, all of them, very, very much to the left of unity, favoring finerenone. And the other points like all-cause hospitalization and all-cause death, those are also to the left of unity, but maybe slightly closer to one. But the significant ones, as you can see there, are the hospitalization, heart failure hospitalization, the atrial fibrillation, the kidney composite endpoints, very significantly there. So remember, this is in a population with heart failure, with CKD, amongst type 2 diabetics. Yeah. Now trying to understand briefly about the GLP-1 receptor agonism in the cardiovascular trials. So what have we seen thus far? We've understood again about the 3-point MACE, about the CV death with liraglutide and semaglutide. We've seen the results with in terms of macroalbuminuria and GFR decline from early to late with lira, with dula, with semaglutide. And of course, the CVD and the CKD benefits have also been shown to be clearly significantly good for the CKD patients. And we saw the FLOW trial, which was actually stopped earlier because the results were so much better with the molecule arm as compared to the semaglutide 1 milligram arm as compared to the other arm, the placebo arm, that was actually stopped prematurely. Here, they were looking at a data from amongst type 2 diabetic patients with a GFR of between 50 to 75, ACR 300 to 500. And they were trying to look at the composite endpoints of time to first occurrence of kidney failure, persistent more than 50% reduction in eGFR, or death from kidney or CV causes. Now, we do, as we said, the results have been so much better with finerenone and so much positive for finerenone that it was stopped earlier, and so it's come out very strict. I'm so sorry, not finerenone, semaglutide. But the study was stopped, and it is firmly established that 1 milligram semaglutide did establish all the composite primary endpoints much better than placebo and significantly. This is what we were seeing. I'm sorry. This is the CKD flow, the CV death, and the non-fatal MI and the non-fatal stroke that we saw. This is the difference between SEMA and placebo, wherein placebo, showed 14.4%, whereas SEMA had 12%. You can see that the p-value being significant there in terms of these outcomes. It was slightly slow in its movement, but yeah, just a minute. So these are like heart failure events and CV death. This is from the FLOW trial. This is diabetic patients with CKD. Now look at the heart failure evidence, the composite heart failure events, including CV death. And here again, you can see if you're looking at a no heart failure, category, and you're looking at a heart failure category, and then you're looking at the difference between the placebo and the arm, the semaglutide 1 milligram arm, you can see there the very, very significant difference that is being seen in terms of, heart failure alone when you're looking at this data, and even when there's no heart failure, and if you're looking at the CV death pattern. This is the total. And when you analyze it in terms of BMI or, the baseline GFR level. So look at the BMI, it's not very different. If you're looking at a baseline GFR level, anything less than 30, the results were way better. 30 to 45, 45 to 60, and more than 60, rather, there's a slight shift towards the right also. Saying that, when you have this category where between 30, less than 30, to 60, you are actually providing the best results when you're putting in semaglutide in the heart failure events and CV death. And in terms of the ACR again, if you had an ACR of more than 300 again, the results were better. KDIGO scores, you can see there with 1+2, it's almost the same. But as you reach 4, it's going to the left. Concomitant medication, diuretic, nothing much. Loop diuretic, again, almost similar. MREs, however, if you were using it, there seems to be slightly difference in the results. SGLT2 usage, again, if you had it, you can see, yes, the results were slightly to the left. So there have been varying results in terms of, the molecules which have been used together. I think it would be interesting to understand why we had that result with the MRAs usage, but this is for, a future analysis that has to be done. We then move on to the all-cause death. The data between placebo, which showed 15.8%, versus semaglutide, which showed 12.8%, with a hazard ratio of 0.8 and a p-value which was significant. So this is something. This is a risk-based, an approach in type 2 diabetes. And what are you trying to understand? You have there is the moderate or the low risk category, where you need to put in the primary care management, and as required, they will need a specialist referral. And then you go on to the higher risk strata, where you would very high risk or high risk strata, where you would definitely need a referral upfront for a nephrologist. And you would also want to put in an accelerated sequence combination therapy. So this is about the accelerated risk-based approach, where you have to identify your patients who are at a highest risk, using a risk score, so that you can identify them early and take a more proactive approach, prioritize the accelerated implementation of the GDMT for these patients. And, then you go on to the risk rapid sequence approach, where you're talking about a rapid or a simultaneous implementation of this, categorizations, assuming that every patient with CKD is at equal risk. And there is a traditional approach where you maximize the RAS blockade and SGLT2, and then you look back at the patient again at 3 to 6 months, and then you add in non-steroidal mRNA if required, or consider a GLP-1 receptor agonist. So, which approach to take, traditional, rapid sequence, or accelerated, is for you to decide. So what we've discussed in the last few minutes, about half an hour or so, is basically we've understood that we have enough data now telling us about the role of SGLT2 inhibitor, of course, with an ACE inhibitor or an ARB as a first-line therapy for CKD for every patient of CKD, irrespective of diabetes today, because you would want to put in an SGLT2 inhibitor unless there is some particular reason why you're not doing it, right? In type 2 diabetics, we have enough data telling us about the non-steroidal MRAs, the GLP-1 receptor agonists. So, these are basically risk-based therapies for albuminuria, for CVD, along with weight management. Semaglutide is the first GLP-1 receptor, which has proved it's better in terms of kidney improvement, in terms of CVD and survival outcomes. Also, the implementation strategies in terms of detection, in terms of awareness, in terms of your proactive approach is something that we really, really need to urgently take over. I mean, we're doing a lot of CMEs, we're doing a lot of webinars, But we'll have to admit that a lot of time we tend to be a little lax in our approach, a little latent in our approach, and probably that might make a lot of difference in the patient's ultimate outcome. So the implementation strategies and so if you could have a planned approach, a proactive planned approach to go about it, maybe we'll have results that are better, that are going to be much better in the years to come. So on that note, I'll end my presentation, and thank you so much for your kind attention.
Thank you, ma'am, such a comprehensive presentation and simplifying holistic approach of diabetes management in chronic disease patients. So now we have second topic that will be taken by Dr. Ameya Joshi, sir. And the topic is GLP-1 agonist and GIP in heart failure, preserved ejection fraction. So what do you, sir?
Thank you, Dr. Kuldeep ji, and also it was a treat to listen to Dr. Arundhati. I hope I am audible and my screen is visible.
Very much audible, sir. Screen is visible also.
The slide has changed.
Yes.
Yeah. So why we treat diabetes, including diabetic kidney disease, is because of the fact that most of them are actually not going to succumb to kidney disease or liver disease. Most of them are actually going to succumb to cardiovascular disease. Most important cause of mortality and morbidity in CKD is also cardiovascular disease. And the most common form of cardiovascular disease in diabetes is heart failure. The global prevalence rate is 22%. Our own institutional data shows close to 30% prevalence in type 2 diabetics who are attending the outpatient setting. Now, this is a prototype case to show a case of today's problem, that's a heart failure with preserved ejection fraction. Gentleman with diabetes and hypertension, normal ECG, never had a heart problem, says occasionally gets breathless, is due for surgery. As a part of workup, we did the NT-proBNP level, and it is mandatory that all patients with type 2 diabetes need to get their NT-proBNP level once in a year. And we end up diagnosing that the NT-proBNP is more than 125. So the patient has actually heart failure. The 2D echo is normal, apparently showing an ejection fraction of 58%, but a carefully done 2D echo confirmed that the GLA score and the LVEDD is raised and there is a heart failure with preserved ejection fraction. The guidelines then change with person with diabetes and heart failure, and the treatment algorithm has to include SGLT2 inhibitors and GLP-1 receptor agonists. We always think that heart failure is a single disease, but heart failure is two different entities. HFrEF presents a bigger challenge with more mortality, which has little improved with life expectancy with the therapeutic armamentarium. HFpEF is widely prevalent. Lot of times it is missed, but it has a longer survival rate, and fortunately now medications that are available. What you need to do in HFpEF, because you can't improve the ejection fraction, you need to take care of the afterload on the heart by reducing the weight, controlling the blood pressure, and better controlling the diabetes. And that is why HFpEF targeted cardiac medications are not there. It is a systemic treatment that improves the HFpEF, and GLP-1 receptor agonists have found a place there. What exactly happens is, with a normal ejection fraction, there is a ventricular remodeling, hypertrophy, and compliance. So it is not a disease where a clinician can merely look at the ejection fraction and say that, okay, EF is normal, everything is gone. It's not like that. Here, you are looking at a stiff heart, which actually increases the risk of heart failure, hospitalization, and mortality and morbidity driven by the systemic complications. And we know that HFpEF is the elephant in the room contributing to the occult burden of heart failure. HFrEF is openly recognized, and obesity is the root cause of HFpEF. 85% of HFpEF are obese. And so first time we actually had a group of medications, SGLT2 inhibitors and GLP-1 receptor agonists, which reduce the mortality and morbidity. GLP-1 receptor agonist is what we are going to discuss today. They came as analogs of incretin. glucagon-like peptide. They reduce the blood glucose, increase insulin secretion, suppress glucagon, and basically reduce the weight and thereby improve the complications of diabetes. Basically, diabetes is fat accumulation everywhere. It occurs in heart, we call it coronary artery disease. It occurs in the liver, we call it fatty liver disease. It occurs in the pancreas and the diabetes develops. And we remove fat from everywhere. 10 to 15% reduction in the body weight actually improves the prognosis in obesity. This is called as obesity paradox. Because an obese person has weight to lose, a clinician has a medication to give, and that translates into much better prognosis than a lean person with diabetes with complications. What we see in the heart is an epicardial adipose tissue. So fat in the liver is measured. Similarly, fat in the heart is measured as epicardial adipose tissue on a 2D echo or a special software dedicated in a CT scan machine. And that if the person has a normal EF with raised epicardial adipose tissue, that indicates that probably we are dwelling on an occult heart failure. The new kid on the block is the clinicians were not only satisfied with GLP, they tried to use different combinations of incretin hormones, and then we have glucose dependent insulinotropic peptide, previously called as GIP, which when added to GLP can give better control of diabetes and magnified weight loss as compared to GLP-1 receptor agonists alone. But not all GLP-1 receptor agonists were cardioprotective. Some of them were, and the saga started with liraglutide, dulaglutide, semaglutide, and now tirzepatide. And we will be discussing about mainly the two landmark trials, one of semaglutide, that is HFpEF in non-diabetics and diabetics, and then we will move on to the tirzepatide trial on HFpEF. So HFpEF study looked at people with ejection fraction more than 45% and BMI more than 30 kg per meter square, with 529 people randomized to receive semaglutide versus placebo. The duration of treatment after the escalation, which is done for 16 weeks, was another 52 weeks, and the primary endpoint was to investigate the effects of semaglutide once weekly on physical function, symptoms, and body weight compared to placebo. And then you looked at secondary endpoints of KCCQ-CCS, body weight, and effort tolerance related endpoints. Then NT-proBNP, NYHA class improving 6-minute walk test, so on and so forth. Semaglutide improved the KCCQ-CSS change from baseline, and there was also a wonderful improvement in the effort tolerance. There was also a reduction in the weight, and the the semaglutide matched the trial expectation. Semaglutide also increased the 6-minute walk test passed by the number of patients, and more number of people were able to complete the 6-minute walk test as compared to the placebo. Now, these two can still be subjective, but then what we do in our setups is NT-proBNP as a standard of care. We are actually managing most of the, it is like like what microalbuminuria is for the kidneys and HbA1c is for diabetes. We look at NT-proBNP as a marker for the heart, and there was a 20% reduction in NT-proBNP that is achieved in HFpEF by semaglutide. That was statistically significant. And higher number of patients with semaglutide as compared to placebo were able to avoid hospitalization, and a higher number of patients on placebo actually had a heart failure event. So semaglutide 2.4 milligram was superior to placebo. It improved effort tolerance, it reduced inflammation, and the body weight also reduced. Semaglutide was well tolerated with less discontinuation rates and better acceptance. The STEP HFpEF was again a study in diabetics, including 616 patients. Here, though diabetics were the patients, and the diabetic dose of semaglutide is 1 milligram, here semaglutide was given up to 2.4 milligrams, and the same way it was tried, the same endpoints were looked at, and it concluded that semaglutide 2.4 milligram was superior to placebo, and it does improve effort tolerance, reduce inflammation, and also the patients were able to avoid hospitalization and were able to do better in terms of their long-term outcome. So this was about what semaglutide does in basically treatment of HFpEF. Now, semaglutide was also a unique GLP-1 receptor agonist, which actually gave a first clear benefit in heart failure with preserved ejection fraction. It also gave a clear benefit in MASLD, and it finds wide applicability, and also it has expanding horizon. It is probably one of the most discussed molecule of the century, I would say, till now. And then we move on to the closest competitor of semaglutide, that is tirzepatide. The difference is GLP and GIP are together. Tirzepatide is actually GIP mimetic with a partial agonism at GLP. Again, Summit was the trial that was done. It looked at patients with chronic heart failure, LVEF more than 50% and BMI more than 30 kg per meter square. The inclusion criteria were very well crafted here with LA enlargement, elevated LV filling pressures, and NT-proBNP more than 200 with sinus rhythm and more than 600 with atrial fibrillation. Remember, NT-proBNP is a standard of care in all patients with type 2 diabetes mellitus, has to be done, and it level beyond 125, you have to diagnose the patient as occult heart failure, do a 2D echo, quantify whether it is HFpEF, HFrEF, start guideline directed treatment. And then again, the enrichment criteria to identify patients at high risk event was 6-minute walk test, Kansas City cardiomyopathy clinical summary score, and heart failure decompensation within 12 months or EGFR less than 70. So after the screening time, placebo or tirzepatide was started, and then the patients were followed up for up to 3 years. So the endpoint was cardiovascular death or worsening of heart failure events, change in KCCQ CSS health status, and change in 6-minute walk distance. The initial projections were 10% annual rate of an event and 20 to 30% reduction in worsening of heart failure with no effect on cardiovascular death. However, the results were encouraging, and the cardiovascular death or worsening of heart failure got an alpha of 0.04 and KCCQ at 52 weeks was 0.01. The Summit trial showed that patients were randomized, 731 patients randomized to tirzepatide versus placebo, and basically 20% discontinued the treatment. The patients were followed up for vital status, and more than 90% of the 98% of the patients, the vital status were available. The trial, this is the comparator and the control group of tirzepatide versus placebo, and they were comparable to begin in terms of most of the parameters, including the distribution across age, gender, racial distribution, BMI, NT-proBNP, EGFR, so on and so forth. And you can clearly see a wonderful reduction with a hazard ratio of 0.62, 38% reduction with tirzepatide. You can see the graph clearly separating at week 20, and the separation gets magnified, and by 52 weeks the whooping reduction in the hospitalization for heart failure and cardiovascular death is seen. Also, the cardiovascular death or worsening of heart failure requiring hospitalization or urgent IV drugs, 43% reduction. Miraculous improvement in heart failure outcomes. Basically, I would say a game changer for people with diabetes. And look at this effect of tirzepatide on worsening of heart failure requiring hospitalization or urgent interventions for heart failure, 59% reduction. I think it's a blockbuster for any patient with HFpEF. And all cause mortality also came down a little, and the effect of tirzepatide on health status KCCQ score, I think once you look at the heart failure hospitalization, it was a clear winner. Improved quality of life and reduced worsening of the heart failure. The Summit trial is the first trial in patients with HFpEF and obesity and had major heart failure outcomes with pre-specified endpoints. Tirzepatide reduced the composite of cardiovascular death and worsening of heart failure by 38%. It gave significant effects to improve the KCCQ CSS scores and 6-minute walk distance, and the safety also was consistent with the past studies. So very encouraging, glaring, and wonderful results. So just if you don't remember the numbers and the complications and the algorithm, this is a simple thing that I prepared. That if you see an obese diabetic, BMI more than 30, your GLPs are going to work very well in a patient with HFpEF. If you have an elderly hypertensive, be little cautious. If you have inflammation, high HSCRP, your GLPs are going to be good. If you have an ischemic disease, the GLPs are still going to be reasonable, and this is a population which actually benefits from intervention. The circulating biomarkers we are fortunate to have, and we'll now see more and more trials which will look at NT-proBNP reduction and the event rate, and the heart disease spectrum in diabetes is going to see very rapid improvement. We'll have better molecules which will give better outcomes and prolong the survival. So to take home, what we see with GLP-1 receptor agonists, the all taken together, 32% heart failure event rate reduction, grade B recommendation. I am sure it will get upgraded with times to come. If you combine with SGLT2 inhibitors, wonderful results and much better outcomes. We have to monitor these patients. We need to understand that 10 to 20% in the real world will stop without financial restriction, and the reports also say that 50% will discontinue the GLP-1 therapy after 1 year. So what is more important is to tell our patients that this is not merely weight loss medication for you, this is a survival prolongation medication for you, and cost though remains a barrier, we have delivered a winner is what I feel in the management of heart failure with preserved ejection fraction in GLP-1 receptor agonist. Thank you one and all for your patient listening, and I hand over the screen to the organizers.
Thank you, sir. Such a wonderful presentation and sharing your insights on GLP-1 agonist and GIP in heart failure, preserved ejection fraction patients. With this, we complete both the sessions, and this is the session of Q&A. So now audience can ask the question in chat box that I'll take it to the,
I think Dr. Arundhati is not there. Maybe.
Ma'am is not there. I think, okay, we'll see. So I'll check it the chat box, sir. Jill, can you just check it? I checked the questions, but you just check it with ma'am.
Okay, maybe till that time I can just take some of them.
Yeah.
So how to manage those SGLT2 at type 2 diabetes with comorbidity? I think the comorbidities with SGLT2 inhibitors actually does not need a manipulation of the dose. It's all or none most of the times, and you can just use it, and if the patient doesn't tolerate, stop it, or if you find a red signal, stop it. Yeah.
So one question is there, sir, from Dr. Manoj. How can we differentiate diabetic nephropathy with hypertensive nephrosclerosis?
I think the clear answer for this is basically done only by a renal biopsy. When you classically see a high proteinuria and you are concerned. So in any diabetic patient with a nephrotic range proteinuria or hematuria or abnormal sediment that is seen on a urine routine microscopy or a rapid progression, I think renal biopsy is indicated, and that's where nephrologist comes in the picture in the early age.
So one more question is there from Dr. Aman. In which stage of CKD should SGLT2 inhibitor be initiated or continued? Ma'am, can you take this question?
Till now tells us that as long as you have a GFR of more than 20 or 25, one study would say 20 and the other 25, you would want to put in an SGLT2 inhibitor for every diabetic patient, no matter what the renal status is, so that you are putting in the benefits of the SGLT2 inhibitor, unless there is some contraindication or unless there is some problem with the usage of SGLT2 inhibitor. So rather than waiting for the GFR level to basically come down and then, initiate, from the very beginning, we would want to put in the benefits of SGLT2 inhibitor till the GFR reaches a cutoff of 20 or 25.
Thank you. One more question is from Dr. Nilesh. When should GLP-1 agonist to be introduced in diabetic kidney disease to improve cardio-renal outcomes?
Okay, so again, if we go by the data that we have in our hands today, SGLT2 inhibitor, we've seen the data. GLP-1 receptor agonist with specific GLP-1 receptor agonist, we've seen the data. So if you're talking about, say, semaglutide, with the flow, you have seen that the difference between the semaglutide arm and the placebo arm was so significantly strong. So now if you say for your HbA1c control or for your diabetic control, you are comfortable using the GLP-1 receptor agonist plus the SGLT2 inhibitor, then you're putting in the benefit at a go. Of course, let's not forget the other benefits that's coming along with it. We had Dr. Joshi tell us very nicely about, the cardiovascular aspects of it. So if you have a patient, you would again want to look at the, the individual patient and then decide whether you want to put in both the SGLT2 inhibitor and the GLP-1 receptor agonist, or do you want to go like one step at a time? Till now, whatever data we have, we would put in the SGLT2 inhibitor first, and as an add-on, as per the KDIGO also, subsequently, when you want to put in the extra benefit, then you would be adding the GLP-1 receptor agonist. It's not a particular GFR cutoff where you would be introducing this. It's like once you put in this and then you want to give an additional effect, then you would want to put in the GLP-1 receptor agonist.
Thank you, ma'am. I think this will be the last question. Dr. Amit has one question. Which heart failure preserved ejection fraction patient is ideal for GLP-1 therapy?
So anyone with a BMI more than 30 and a raised inflammatory marker is going to be maximally benefited in HFpEF if you start GLP-1 receptor agonist.
Great. Thank you, sir. Thank you, Amay sir, as well as Arundhati ma'am for clarifying all the doubts and questions that we have seen today, and wonderful and meaningful presentations on both the topics. I request Mr. Abhijit to have a vote of thanks from Lloyd.
Sure.
Thank you for the opportunity.
It was absolutely wonderful destination of the topic by both the speakers. I would like to thank Dr. Arundhati Dasgupta and Dr. Ameya Joshi for this wonderful destination of the topic. And also would like to thank all the audiences for making this program successful as well as memorable. With this, I announce the conclusion of today's topic. Thank you. Thank you so much, madam and sir. Thanks.
Last announcement, next month, which we have next session of this journal club program with international speakers. So for the date and time, which we are going to update very soon for the audience. Thank you. Thank you very much.